Clinical trial of fluid infusion rates for pediatric diabetic ketoacidosis.
Definition.
Diabetic ketoacidosis in children may cause brain injuries ranging from mild to severe. Whether intravenous fluids contribute to these injuries has been debated for decades. Early theories to explain diabetic ketoacidosis related brain injury suggested that rapid administration of intravenous fluid reduced serum osmolarity, which results in brain swelling.
Brain injury is an uncommon but important complication of pediatric diabetic ketoacidosis. One hypothesis has been that rapid infusion of intravenous fluids during treatment causes a reduction in serum osmolality, leading to brain edema and injury. Current recommendations based on retrospective studies suggest using a slow infusion of isotonic fluids. In a multicenter randomized clinical trial with a 2x2 factorial design, investigators evaluated 1,389 episodes of diabetic ketoacidosis in 1,255 children from 13 urban emergency departments in the United States. The children were assigned to either a rapid or a slow infusion strategy, and all received an initial bolus of 10 milliliters of 0.9% sodium chloride solution per kilogram. The rapid infusion group received an additional bolus of 10 milliliters of 0.9% sodium chloride solution per kilogram, and a fluid deficit of 10% of body weight was assumed, of which half was replaced over the initial 12 hours and half over the next 24 hours. The slow infusion group did not receive an additional bolus, and a fluid deficit of 5% of body weight was assumed, and was replaced evenly over 48 hours. Within each infusion group, children were assigned to either 0.45% or 0.9% sodium chloride solution for replacement after the initial fluid boluses. All other treatments for diabetic ketoacidosis were identical. The primary outcome was a decline in mental status, as defined by a Glasgow Coma Scale score of less than 14. Scores were obtained hourly for 24 hours or until the resolution of diabetic ketoacidosis. There was no significant difference in the rate of the primary outcome between the rapid and slow infusion groups, or between the 0.45% and 0.9% saline groups. Serious adverse events were rare and occurred with similar frequency in all groups. The authors conclude that neither the rate of administration nor the sodium content of intravenous fluids significantly influences neurologic outcomes in children with diabetic ketoacidosis. Full trial results are available at nejm.org.
Application in nursing. Children were eligible for trial enrollment if they were between 0 and 18 years of age and have received a diagnosis of diabetic ketoacidosis taken by nurses, defined as a blood glucose level of greater than 300 mg per deciliter and a venous pH less than 7.25 or a level of serum bicarbonate less than 15 ml per liter.
Hello, in this video we're going to talk about diabetic ketoacidosis. This is an introduction and overview. It is important to know that diabetic ketoacidosis is a medical emergency, especially in type 1 diabetic patients. But it is known that it can also occur in type 2 diabetes. As the name suggests, it has to do with acidity. So there's increase in acidity in the blood, essentially. The signs and symptoms of diabetic ketoacidosis is nausea, vomiting, polyuria, polydipsia, weight loss, hyperventilation, known as Kussmaul's breathing. Now, diabetic ketoacidosis doesn't occur out of the blue. There's usually some triggers. And these triggers, these etiologies, it can be remembered as the 5 I's. The 5 I's are infection, intoxication, inappropriate withdrawal of insulin, infarction, and intercurrent illness. And these 5 triggers, they cause what we know as diabetic ketoacidosis. So let's go into the pathophysiology briefly. If you want to know more about the functions of insulin, watch a video I have on the fed state, which is under biochemistry. Anyways, the pancreas normally produces insulin. However, in diabetes type 1, there is an autoimmune attack on the B cells, which normally produce insulin. And therefore, insulin is not being produced anymore. So we have a decrease in insulin. Insulin is an important hormone. And because we have a decrease in insulin, this causes some problems. First, it means that gluconeogenesis is not inhibited. And so we get gluconeogenesis. We get more production of glucose. We also get increased glycogenolysis, and we get a decrease in glycolysis, all of which will result in more glucose in the blood. So we get hyperglycemia. Hyperglycemia results in glucose being peed out. So we get glucoseuria. Glucose draws water, so we get polyuria, and we also get dehydration as a result. Because we lose a lot of water and we are dehydrated, we get polydipsia. We get thirsty. It's also important to note that the decrease in insulin, the absence of insulin, means that fat breakdown occurs. It's a very important concept to understand. Fat breakdown occurs especially if the body is not receiving enough energy. So in periods of infection or feeling ill, the body will start breaking down the fat because glucose is not present and because glucose is not being taken up. Fats get broken down from adipose tissue to form free fatty acids, which then go to the liver and undergo ketogenesis to make more ketone bodies. It does this because the body needs some form of energy, some form of supply, because glucose is not working or because glucose is not present.
Pros and cons.
Disadvantage: neurological state disorder, lessen forthin during any hours within the first 24 hours of treatment for diabetic ketoacidosis, shorten memory during the treatment of diabetic ketoacidosis. Advantage: during the course of the trial, the Glasgow Coma Scale score decreased to 3.5% of these episodes.
With so much ketones being made, we get ketonemia. We get high ketones in the blood. And then subsequently, this means that we get ketonuria. We are peeing out ketones. And it's also important to know that ketones are acidic. Ketones are acids, and so they reduce the pH in the blood, but also they will reduce the pH in urine. This is the main pathophys we see in DKA. So if a person presents with the signs and symptoms we spoke of, a thorough history and examination needs to be done, and appropriate management needs to be performed, which includes checking the airways, checking breathing, and circulation. In circulation, IV access is important for a few reasons. First, to get bloods for investigation. It's also important here to get a base serum potassium level. After getting the bloods for investigation, administering IV fluids, saline, and also administration of insulin slowly is very important. Administration of insulin is important because we want the cells in the body to take up the glucose that is in the blood. While this is going on, investigations have to be performed. So ABG, which is arterial blood gas, is very important to measure the pH in the blood, and this needs to be done regularly. Bloods, as we mentioned, full blood count, EUCs for infections and also electrolyte abnormalities and dehydration. Urine analysis is important to check and monitor if there's glucose, ketones, and infections. ECG is performed to check for arrhythmias in case of potassium hyperkalemia or hypokalemia.
Issues apply in Ecuador. In the Francisco de Casa Bustamante Children's Hospital between January 2008 and December 2013, the diagnosis of diabetes ketoacidosis, 71% of patients correspond to children greater than 5 years old, of which 34.2% were 10 years old.
So again, monitoring pH by doing regular arterial blood gas is important. And also it is important to monitor serum potassium levels. The reason it is important to measure serum potassium levels is insulin is being administered, because insulin will actually cause hypokalemia. If you get hypokalemia, you can actually trigger an arrhythmia. Sometimes calcium gluconate can be administered to protect the heart from these hypokalemia-induced arrhythmias. Anyways, monitoring is continuous. Check pH and check bloods. After a while, you can switch the fluids to 0.5% saline and 5% dextrose. This is done when blood glucose goes down at least about 14 millimoles per liter, let's just say. Again, for diabetic ketoacidosis, monitoring is essential. Monitor bloods, EUCs, perform ABGs to check for pH, and monitor urine output, and also the changes in urine pH, glucose, and ketones.
Conclusion: neither the administration rate nor the sodium chloride content of intravenous fluid significantly influenced the neurological outcomes of diabetic ketoacidosis in children.
Let's talk about the two-bag system for fluid administration in diabetic ketoacidosis. Two bags are used simultaneously to deliver fluids, electrolytes, and dextrose to patients in DKA. This allows for easy adjustments in the percentage of dextrose by varying the infusion rates of each bag. This results in a significant decrease in the number of bags of fluid required per patient throughout their hospital stay. Both bags have the same composition of saline, generally either normal saline or half normal saline, and electrolytes. Only one bag has 10% dextrose. This picture illustrates the setup. So you can see bag 1 is composed of saline and electrolytes, and bag 2 has 10% dextrose, saline, and electrolytes. Note that the composition of electrolytes is the same in either bag, either 20 milliequivalents per liter of potassium chloride and 20 milliequivalents per liter of potassium phosphate or potassium acetate. You can also Y in the insulin, and as you can see, at an appropriate drip rate, this makes patients happy, or at least helps correct the acidosis. Now, in terms of figuring out the fluid rate, you're going to need the body surface area. So you can either do a square root by hand or use a handy online calculator. I'll leave it up to you to decide which one you're going to use. So for a 10-year-old male who's 40 kilograms and 140 centimeters tall, his body surface area is approximately 1.24 meters squared. The fluid rate is about 100 milliliters per hour. It's actually closer to 101, but let's face it, this is for demonstration purposes and I like easy math. So, in order to get a composition of dextrose 10% or D10, bag 1 runs at 100 mLs per hour, bag 2 at 0 mLs per hour. D7.5, 75 mLs per hour, 25 mLs per hour, and yes, you guessed it, D5, 50 mLs per hour, and 50 mLs per hour for each bag. As you can see, this is a very straightforward and easy way to conserve fluid and make abrupt changes to the dextrose concentration while you're treating a patient with DKA.